evening, and welcome to ASE's Guideline Webinar Series. Today's webinar is titled, Performing a Comprehensive Transesophageal Echocardiography Exam, a Guideline in Review. Before we get started, I have just a few housekeeping items that I would like to go over with you. First, we do encourage you to download a copy of the guidelines associated with this presentation, which is found in the resource section of this player. Next, since this is a live webinar, you do have the opportunity to have your questions answered by the speaker. To ask the speaker a question, click on the question mark icon in the left-hand toolbar and type and submit your question. You may do this at any point during the presentation. However, questions will be answered at the end of the presentation. We'll do our best to ensure that all questions are answered. However, this may not be possible depending on the number of questions presented. We also have a Help tab to the right of the chat. If anyone has any technical issues, they can click on that tab to submit a ticket, as well as look over some other useful information, frequently asked questions, tech support number, etc. To claim your CME for this session, you must be logged in for the full event. At the end of the session, you will be automatically redirected to a new page. Once there, find the name of the session and click on the evaluation link. Complete the evaluation and a certificate will automatically be generated and saved to your CE transcript on your ASE University profile. Without any further delay, let me introduce today's speaker, Dr. Rebecca Hahn. Dr. Hahn has no disclosures to make in relationship to this activity. Dr. Hahn has been a member of the American Society of Echocardiography, ASE, since 1990. She has previously been a member of the ASE Finance Committee and the Board of Directors. She currently is the Continuing Medical Education Committee Chair and a member of the Education Committee as well as the Council of Intraoperative Echocardiography. Dr. Hahn is a Director of Interventional Echocardiography at the Valve Center of Columbia University College of Physicians and Surgeons. Dr. Hahn, I will now turn the presentation over to you.
Thanks, Rana. On behalf of the entire writing committee and the American Society of Echocardiography, I'd like to welcome you to the webinar on the guidelines for performing a comprehensive transesophageal echocardiographic examination. As Rana has stated, you can get the guidelines in the reference folder that is associated with this player. I have no disclosures, as Rana has already said, and then the ASE staff also that's associated with this presentation has no conflict of interest or anything to disclose. There's a disclaimer that's actually in the guidelines, and I just want to remind everyone that this is a recommendation that's primarily based on the opinion of experts. The information provided during this activity is for continuing education purposes only and not meant to substitute for any independent medical judgment of the healthcare provider. Hopefully by the end of this presentation, the viewer should be better able to list the general indications, contraindications, and appropriate use for a comprehensive TEE examination, as well as describe the general assessment and preparation of a patient, recognize and acquire the new 28 views comprising a comprehensive TEE examination, and explain the use of these 28 views as well as additional views for specific structural imaging. With the significant advancements in technology, TEE has proven utility in a number of clinical arenas, including the operating room, the intensive care unit, the interventional laboratory, as well as the outpatient setting. And so TEE has become an essential imaging tool for a number of different physicians, including cardiac surgeons, anesthesiologists, cardiac interventionalists, and clinical cardiologists. This new TEE guideline that we present today reviews all the aspects of TEE training and image acquisition, much of which I will not be able to cover in this short 1-hour period. It also provides a current definition of what we consider a comprehensive TEE examination, naming a set of 28 TEE views intended to facilitate and provide consistency in training, reporting, archiving, and quality assurance in multiplane TEE examinations. In addition, we will review additional views for structure-specific imaging and summarize the acquisition protocol for three-dimensional transesophageal imaging. In general, we recommend the performance of a comprehensive or complete TEE examination whenever possible. The order and number of views, however, may differ for various indications. The comprehensive imaging views discussed previously, the 20 suggested views, are not intended to represent all the imaging planes that can be obtained And the current 28 views in it also do not intend to cover all imaging planes that can be used. So in the structural imaging section of the guidelines, we attempt to add additional views that you may consider, understanding, again, that one must always balance a complete echo with an expeditious completion of the examination. Organizations accrediting hospitals and facilities recognize certain performance standards, and each facility has to understand that it has its own policies, and those will not be covered in this webinar. There are several published guidelines addressing training and maintenance of certification for physicians performing TEE, and they are summarized in the first table of the guidelines that you can see here. The references for this table are included in the guidelines as well. The minimum knowledge required for performance and interpretation of TEE and perioperative echocardiography in adults is addressed in the ACC Clinical Competence Statement on echocardiography and is listed for reference again in tables 2 and 3 of the guidelines. Again, I refer you to the guidelines for the list of these references. Although several general indications are listed on this table, table 4 of the guidelines, the complete list of explicit indications is not possible, given the diversity of the diseases and clinical scenarios in which echocardiography is utilized. In general, a TEE may be warranted whenever findings may alter management, and those findings cannot be or are unlikely to be acquired by routine transthoracic imaging. In addition, specific procedural indications, including intraoperative TEE and guidance of transcatheter procedures, has become a new indication for TEE in the operating room as well as the catheterization laboratory. Given the many uses of TEE and the potential for over or unnecessary use, the appropriate use criteria approach is a worthwhile methodology when considering TEE indications and has been advocated by the Intersocietal Accreditation Commission for Echocardiography. The recently published appropriate use criteria for TEE is not all-inclusive and does not include intraoperative or intraprocedural indications. However, it did identify 15 common scenarios encountered in practice and where TEE is the test of choice. And these are, again, listed in the guidelines under a separate table. Relative and absolute contraindications for TEE are listed in Table 6 of the guidelines. Patients with relative contraindications to TEE, such as history of radiation, GI surgery, recent upper GI bleed, Barrett's esophagus, history of dysphagia, etc., should be evaluated on a case-by-case basis to determine if the benefits of the procedure performed with appropriate precautions, such as not advancing the probe past the mid-esophagus or limiting probe manipulations, may exceed the potential risks of the complication. In addition, a list of complications as reported in the literature is presented in Table 7 of the guidelines. The important parts are that the overall complication rate is approximately less than 3% for diagnostic TEE and less than 0.5% for intraoperative TEE. Uncommon complications are major bleeding, esophageal perforation, and death, occurring in less than 0.1 to 0.2%. Common complications are hoarseness and lip injury, but other complications remain extraordinarily rare. There are three groups of patients to consider when discussing management of sedation for an individual requiring a TEE: an awake patient, either ambulatory or an inpatient, a ventilated patient in the intensive care unit, or the anesthetized patient in the operating room. Physicians performing a TEE in the echo laboratory must manage conscious or moderate sedation. Patients under conscious sedation should have purposeful response to verbal and tactile stimulation with spontaneous ventilation without need for airway support. Patients undergoing a procedure with sedation should abstain from food and beverage other than clear liquids for a minimum of 6 hours prior to the procedure and restrain from all intake for 3 hours prior to the procedure. Obviously, those patients with delayed gastric emptying or other aspiration risks may need longer periods of fasting. Patients can be instructed to take their medications on schedule with a small sip of water, and monitoring during conscious sedation requires, at a minimum, the assessment of heart rate, non-invasive blood pressure monitoring, the respiratory rate, and oxygen saturation. Conscious sedation is typically defined by the modified Aldrete score, which we will review in just a second. The physician must screen the patient for medical problems and contraindications which increase the risk of conscious sedation. The use of the ASA, or American Society of Anesthesiologists, physical status classification is listed in Table 8 of the guidelines and is recommended as part of the pre-procedural screening. An ASA status of 3 or higher are at higher risk for cardiac and pulmonary complications, and appropriate precautions should be made. Although imperfect, the anesthesiologists also use the modified Aldrete score and also the Malampati airway classification. The Malampati airway classification, as you can see in this picture, shows class 1 through 4, and those patients with grade 1 airway typically are easy to mask and ventilate and intubate, whereas those with grade 4 are difficult to ventilate and intubate. Consequently, evaluating the patient and grading them their Malampati score will help in assessing their risk. Sedation suggestions are included in the guidelines, but obviously there may be hospital guidelines that will dictate the medications and the dosing that are used. Awake patients usually will have their oropharynx anesthetized with topical administration of a local anesthetic. The risk of methemoglobinemia with excessive use of benzocaine is rare, but possibly life-threatening. And so one should be able to recognize methemoglobinemia and treat it with methylene blue. These are outlined in the guidelines in detail. The most commonly used sedative agents are benzodiazepines due to their anxiolytic properties, midazolam being usually the best choice because of its quick onset and short duration. And opioids are used to offset the discomfort of probe insertion and manipulation. Typically, fentanyl and meperidine are most commonly used, with fentanyl now being preferred. At the conclusion of a transesophageal echo on an ambulatory patient, vital signs should return to within 10% of their baseline score prior to discharge to home or return to the ward. Moving on to the actual procedure, there are a number of different ways that the probe can be manipulated. Obviously, one can advance the probe further into the esophagus and down into to obtain the transgastric views, or withdraw the probe. And what you will see in the acquisition protocol are indications of some of these movements in order to acquire the images. In addition, the probe can be turned within the esophagus. So turning to the right, which is a clockwise rotation, will tend to image those structures that are to the right, obviously, of the esophagus and to the right side of the heart. Turning to the left, or counterclockwise rotating, again, will rotate the entire probe to face the left side of the heart or the left chest and are appropriate for imaging left-sided chest structures. In addition, the probe can be flexed in 4 different directions using 2 control wheels located on the probe handle. The large control is for motion in the anterior-posterior axis, and the smaller control is for motion in the lateral or right and left axis. You can see them, again, imaged here in the figure from the guidelines. In addition, the transducer angle can be manipulated, and this forms the basis for a lot of our imaging. The transducer angle of rotation occurs in a counterclockwise manner, similar to what is depicted in the little cartoon and what you can see actually on your screen. So going from 0 to 180 degrees, the angle of the rotation within the probe is a counterclockwise rotation. It's important to understand, however, that the transducer plane rotation is in relation to the structures in space as well. In this example of the mitral valve imaging from the mid-esophageal plane, the plane of imaging is rotating counterclockwise if you're looking at the face of the probe. So just as is depicted in this image here, going from 0 to 180 degrees is a counterclockwise rotation. However, if you're looking at the surgeon's view of the mitral valve, you are actually positioning yourself behind the probe. And because you're positioning yourself behind the probe, that counterclockwise rotation now becomes what looks like a clockwise rotation when we obtain the views at 0 degrees for a 4-chamber, 45 to 75 degrees for the commissural view, 90 degrees for the 2-chamber view, and 125 to 135 degrees for the long axis view. The 28 views of the comprehensive TEE examination include 8 additional views compared to the 1999 guideline. These views include the mid-esophageal 5-chamber view, a mid-esophageal modified bicable tricuspid valve view, the upper esophageal right and left pulmonary vein views, the mid-esophageal left atrial appendage view, the transgastric apical short axis view, the transgastric long axis view, and 2 transgastric right heart views, the right ventricular basal view and the right ventricular inflow-outflow view. These additional views emphasize the imaging of all cardiac structures in the comprehensive TEE examination. They are presented in a suggested order, which may reduce the number of manipulations required to complete an examination. So we'll start with view 1, which is the mid-esophageal 5-chamber view. And as you initially insert the probe into the esophagus, one of the first views that you'll get in the 0-degree transducer angle will be this 5-chamber view. As you further insert the probe and advance it into the esophagus, you'll see the 4-chamber view. This will sometimes require retroflexion in order to get the aorta out of the view. And then as you start to rotate the transducer angle toward 50 to 70 degrees, in again the mid-esophageal view, you should reach the mid-esophageal mitral commissural view. The commissural view ends up being an extraordinarily useful one, which I will show you later when we're talking about 3-dimensional echocardiography. The next view, when further rotating the transducer angle between 80 and 100 degrees, is the mid-esophageal 2-chamber view. In this view, obviously, the anterior wall is to the right of the screen, the inferior wall is to the left, and as you further rotate, and we'll talk about other structures and other ways of identifying what is anterior and what is posterior as we in further slides. As you continue to rotate further from 100 to 120 to 140 degrees, you reach the mid-esophageal long axis view, where you have the aortic valve as well as the mitral valve in view. This is then the anterior septum on the right side of the screen and the infraposterior wall on the left-hand side of the screen. Now, when you withdraw the probe and typically anti-flex, you should get to the mid-esophageal long axis view that emphasizes the aortic valve and the aortic root. In this view, this is obviously one of our major views that we use when doing our transcatheter valve therapies intraprocedurally, but this is an extraordinarily useful view to look not only at aortic valve cusp motion, but when applying color Doppler to look for aortic regurgitation, as well as other pathologies of the aorta. When just withdrawing the probe, you'll start to see the long axis of the ascending aorta. Now, because the aorta in the body curves from the right side to the left as you reach the aortic arch, the transducer angulation typically has to be brought back toward the 90-degree plane in order to get a nice long axis view of the ascending aorta. If one then rotates back from this view, and typically I'll stop when withdrawing the probe when the right pulmonary artery is in the center of the sector. When you then rotate backwards from exactly this level of the esophagus, you should get to the mid-esophageal ascending aorta in short axis, which gives you a bifurcation view of the pulmonary artery. From this view, you can sometimes see the pulmonic valve. You can sometimes Doppler the pulmonic valve and get flow characteristics at the level of the valve. Not infrequently, the left pulmonary artery will be shadowed out by the bronchus that crosses at approximately this level. If you clockwise rotate, which means rotating to the right, so you're moving the probe and just clockwise rotating to the right side of the heart at the same level as the ascending aortic short axis view, you should see the right pulmonary vein. This is a view of the right superior and the right inferior pulmonary veins, as well as the superior vena cava. Now, from this view, you can also Doppler, looking for reversal of systolic flow in the setting of mitral regurgitation. You may end up having high flows if there's obstruction following an ablation or something, or some other manipulation of the vessels. Once you have seen the pulmonary veins, we'll typically advance the probe into the esophagus and return it to the midline by counterclockwise rotating. And from here, rotate the transducer angle to 25 to 45 degrees in order to get this view of the short axis of the aortic valve. From this view, you can see in this particular example the left coronary cusp. The right coronary cusp is now in the bottom of the screen, far field, and the non-coronary cusp always faces the interatrial septum. So you can see here again all three cusps and evaluate mobility of the leaflets as well as with color Doppler any regurgitation. From there, if you further rotate up rotate the transducer angle to about 70 degrees, you will typically bring in the pulmonic valve a little bit clearer, the pulmonic and the tricuspid valve. It may require that you advance the probe slightly, and it may require a little anteflexion in order to get this view of the pulmonic valve. This is the view in which we like to look and try and measure the diameter of the RV outflow tract, for instance, if you're trying to calculate the right ventricular stroke volume. It's also a view that we like to evaluate the tricuspid regurgitation in, since not infrequently the tricuspid regurgitates face into the interatrial septum and may be quite on axis in this view. But if not, then we go to what's called the mid-esophageal modified bicaval tricuspid valve view. And now a little hard to see in this particular example. I'll show you another one later on, but this is the tricuspid valve in the bottom. And because, again, the regurgitation for many tricuspid valves tends to face in toward the interatrial septum because the septal leaflet is very short, you are actually quite en face to the jet from this mid-esophageal modified bicaval tricuspid valve view. And again, one of our favorite views for getting an on-axis view of the tricuspid regurg and getting a continuous wave Doppler across it for an estimation of PA pressures. If you further rotate the transducer angle to 90 to 100 degrees in the mid-esophageal view, sometimes slightly clockwise rotating toward the right heart, you'll get a bicaval view. This is obviously an extraordinarily important view for interventionalists, but also for anyone evaluating the interatrial septum for atrial septal defects or patent foramen ovale. So in patients who come for evaluation of stroke, this is one of our main views for looking at the fossa ovalis. This is the limbus of the fossa ovale. The limbus is the tissue on the right atrial side of the interatrial septum, and the patent foramen ovale will typically be in this region with a flap-like opening. From this view, you can see the right pulmonary veins if you just further clockwise rotate, further clockwise to the right. But what we've done in the guidelines is gone ahead and taken you all the way around to the left side of the heart to look at the left pulmonary vein. And so if you just counterclockwise rotate all the way around the heart toward the left side, in doing so, you'll pass the left atrial appendage, which we're going to look at in a second. and continue on to get to the left superior and inferior pulmonary veins. From here, again, you can do your Doppler and assess the patency as well as reversal of flow in the pulmonary vein. A slight clockwise rotation will yield the left atrial appendage. Now, this view has become extraordinarily important in the setting now of looking for clots for patients with stroke, but also because we are starting to close some of these appendages with either intracardiac or extracardiac devices. So evaluating the left atrial appendage with Doppler, color Doppler, as well as pulse wave Doppler is also an important aspect. I'm going to show you some images of that in a minute. Finally, we'll advance the probe to get into the transgastric views. And the initial view of the left ventricle typically requires some anteflexion. Remember, again, in the transgastric view that your probe is going to be in the fundus of the stomach. So there's a little bit of room to play in there, but also it means that your probe may be quite far away from the diaphragm and therefore from the heart. And so anteflexion tends to regain contact with the wall of the stomach, which should be obviously in direct contact with the diaphragm and the left ventricle. So anteflexion, again, key for obtaining the images of the ventricle at the base where you see the where you see the mitral leaflet. Then with a little relaxation of the probe, you can get to the mid-esophageal level where the papillary muscles are. And then finally, with full relaxation or sometimes retroflexion, you may get the apical short axis view. In addition, you can get this view if you further advance the probe into a deep transgastric view. From a deep transgastric view, again, a little bit of anteflexion may allow you to get a perfect short axis of the apex. Now, from this deep transgastric view, with a view of the LV apex, simple anteflexion with clockwise, typically with a little clockwise rotation to the right heart, will get you this beautiful view of the RV, transgastric RV basal view. You should see the tricuspid valve leaflets, which you do here. You should see the right ventricular outflow tract and the pulmonic valve in the far field. By just using your lateral or small wheel and rightward flexing the small wheel, you may actually get and should get the transgastric RV inflow-outflow view. Now, this view can also be obtained, the inflow-outflow view can be obtained using the simultaneous multiplane imaging from this original RV basal view. We'll show you that also in later slides. Then continuing to be in a deep transgastric view, or sometimes going even further and deeper transgastric, flexion, anteflexion, and left flexion will yield this deep transgastric 5-chamber view and be on axis for Doppler of the aortic valve. This view may also give you an on-axis view of the mitral regurgitation, and continuous wave Doppler of the mitral valve can also be performed. And occasionally you will get a view of the tricuspid valve, which may allow you to do tricuspid Doppler and get the highest velocity of the tricuspid continuous wave. If you rotate from a mid, and if you withdraw the probe and rotate to 90 to 110 degrees, you should get a 2-chamber view, left ventricular 2-chamber view from a transgastric window. This view can be useful for looking at the mitral valve and subvalvular apparatus, obviously also for assessing wall motion all the way from the base to the apex of the LV. If you then rotate clockwise, again, any type of clockwise motion gets you to the right side of the heart. Counterclockwise gets you to the left. So from this 90 to 110 degree view, if you clockwise rotate, you should get the transgastric right ventricular inflow view. This gives you, again, the anterior wall of the RV going out to the RV outflow tract, and the inferior wall of the right ventricle as it is adjacent to the diaphragm. The tricuspid valve, obviously 2 of the tricuspid valve leaflets are well imaged. typically septal and posterior leaflet, but it could be a little bit variable. And Doppler can be performed. With a little bit of manipulation, you may actually see the pulmonic valve. If you further rotate the transducer angle up to 120 to 140, similar to if you were in to the level of the mid-esophageal views, in the transgastric view, you should obtain the transgastric long axis view. This can be extraordinarily useful, particularly if you are unable to get the deep transgastric 5-chamber view. This view will not infrequently allow you to see the aortic valve on axis for a Doppler across the valve for peak velocities and mean gradients, and is one of our favorite views, particularly for aortic stenosis patients where we can't get the 5-chamber view. As you withdraw the probe and counterclockwise rotate all the way to the aorta, you should be able to get at the 0-degree view, this short axis view of the descending aorta. You can also get in the 90-degree view the long axis view of this the same aspect of the aorta, and this is useful for evaluating atheromatous disease, dissections, and other pathology such as penetrating ulcers and transections, etc. As you continue to withdraw, we image the entire way as we withdraw further into a high mid-esophageal view. And in this upper esophageal view, the aortic arch will come into view. And once you start to see the aortic arch, clockwise rotation will yield this long axis view of the aortic arch. In addition, the innominate vein not infrequently is seen. And as you rotate from this long axis view to a short axis view, not infrequently you will see in the far field the main pulmonary artery and the pulmonic valve. And that's view number 28 and completes the comprehensive transesophageal view. Now, I want to go ahead and cover in the last 20 minutes or so some of the uses of three-dimensional echo and then some of the extra views that we use for structural imaging. The guideline, this three-dimensional TEE guideline published in 2012 is also in your reference folder for download if you care to. Now, when we discuss the use of three-dimensional imaging, I think one of the most useful things that we have is simultaneous multiplane imaging. This modality is unique to the matrix array transducer and permits the use of a dual screen to simultaneously display two real-time 2D images. The first or primary view is the reference view, and the second view, typically being orthogonal to the primary view, can, however, be any angle from 0 to 180. So although it defaults to 90 degrees from the primary view, you can actually change the secondary view to be any degree from 0 to 180. The 90-degree orthogonal image, you have to remember, is oriented as if it were forward rotated from the primary view. And remember, when you forward rotate, you are counterclockwise rotating the image within the probe. So once the primary imaging plane reaches 90 degrees, so in this view in E here, and again, this is all in the guidelines, then the secondary view, the orthogonal multiplane view, may appear reversed compared to the standard single imaging plane. So just don't forget that once you hit 90, your orthogonal view is going to look reversed from what you're used to imaging as a single plane. And once you understand that, I think it's pretty easy to use the multiplane imaging for morphology. The beauty of the multiplane and the significant advantage of the multiplane imaging is that you can direct, again, the secondary plane to any image along the primary imaging plane. So in this view, we're looking at the valve, but in this second view, we're looking at the left main. We could actually move the secondary plane over and look at the mitral valve if we wanted to. And so the tremendous utility is being able to image an orthogonal view of any plane in the primary view. But the limitation, obviously, is that there's a lower frame rate. So anytime you ask the machine to do any kind of three-dimensional imaging, there's going to be some sacrifice, tend to be a sacrifice in the frame rate. And so this is the same patient who is imaged with a single-plane short-axis view at the left main and obviously also the right coronary. And you can see that the frame rate is 50 versus a multiplane imaging frame rate of 29. So as long as you understand the trade-off using three-dimensional imaging, either multiplane or full volume 3D, then I think you'll be able to use these tools most appropriately. So again, in the simultaneous multiplane imaging of, let's say, the mitral valve, we will get ourselves reversed once we hit 90. So here we are looking at a two-chamber view, and this is the reverse of the four-chamber view. So here's your four-chamber and the normal two-chamber, and here's your two-chamber at 90 degrees with the reversed four-chamber. The same thing will occur when you're at your commissural view. You'll see this beautiful three-chamber view, because that's how we normally will look at it, forward rotated. But when we are in the three-chamber view, we are now in a reverse commissural view. The clues to the orientation of the mitral valve are to look for the coronary sinus, which is always going to be in the posterior annulus. If you see a left atrial appendage, that's a lateral structure. If you see any aortic root at all, then you know that's the anterior part of the heart. And so using your knowledge of the anatomy will help you when you get turned around a little bit. Otherwise, just turn off the multiplane and try and figure it out using single plane. But multiplane, again, very, very useful. So again, here are the reverse views of each other, a long axis view with a short axis of the aortic valve in the orthogonal plane, and a short axis primary view with the long axis aortic valve in the secondary plane. And so you can see here, because we're used to looking at the aortic valve in this view, that you see the left main coronary artery arising from the cusp that's on the right posterior side of the aorta. But in the orthogonal view here, it's reversed, and so this is the left main on this side. So the clues to the orientation are that the right coronary cusp is adjacent to the right ventricular outflow tract. The non-coronary cusp is always adjacent to the interatrial septum. So if you see interatrial septum, you know that this is not the left coronary, but the non-coronary cusp. And obviously the left main coronary artery arises from the left coronary cusp. And you should never get confused if you remember those anatomic keys. We also like to look at multiplane imaging of any structure in order to help us understand the morphology of those structures. These are just examples of a biplane image, multiplane imaging of the bicable view. And importantly, you can see the tricuspid valve here and the aortic valve here. So when you assist, for instance, in a transeptal puncture, you know that you can avoid the aortic valve using your simultaneous biplane. You can also look, obviously, at the pulmonic valve and the pulmonary artery. You've seen these views before, remembering, again, that when you're using the biplane imaging, you're going to get the reverse of the bifurcation view of the PA. And in your upper esophageal view of your short axis of the aortic valve, you can image the long axis of the pulmonic and use your biplane imaging to try and get to the other two cusps of the pulmonic valve. Again, those are indicated as right coronary, left coronary, and the anterior cusp of the pulmonic. In the guidelines, as well as in Dr. Lang's 3D guidelines, there's the appropriate orientation of the three-dimensional views for structural imaging as well as valvular imaging. We've summarized them in the TEE guidelines as well, and I refer you to the table in the guidelines. In addition, we attempt to show you the various protocols one can use to acquire the images and then reorient yourself to the appropriate views as depicted in the 3D guidelines. But importantly, as transducers and software programs advance, there will be a variety of other things that will be available to you that I may not even know what's coming in the future, even now. But this is one of those software advances where we can now image simultaneously on two different sides of a structure, and this can be extraordinarily helpful. This is obviously aortic valve from the aortic view as well as the aortic valve from the LV outflow tract view. This is the mitral valve from the left atrial view as well as the mitral valve, simultaneously the mitral valve from the ventricular view. So the dual plane imaging may become very useful. If we now move on to specific structural imaging, I'm just going to show you some pretty pictures and kind of talk about a variety of different ways that you can look at other structures. This is using, again, simultaneous multiplane imaging with the commissural view as your primary view, and therefore your long-axis view as your orthogonal view. And you can see that there are multiple jets, small mitral regurgitant jets in this commissural view. But when you think about how to acquire the best imaging for three-dimensional echo, we want the highest frame rates possible, covering, obviously, the anatomy that's of importance. So in this particular case, in the mitral valve, we know that the mitral valve, which is very oval-shaped, will be longer in one dimension than it is in the other dimension. So it's going to be longer in this commissural view, and the orifice is shorter in the long-axis view. So consequently, if you use the primary imaging view as the commissural view, you can use the real-time live narrow sector 30 by 60 narrow angle pyramidal volume to get in a single beat without splicing both the two-dimensional imaging, three-dimensional imaging without color, as well as three-dimensional imaging with color. So this is a single beat, non-spliced view. You can see that the wide angle is going to be in your primary view, so this is the lateral plane, and then the elevational plane is your orthogonal view, which is going deep into the back of the screen. And in one beat, you can get this beautiful three-dimensional look at the regurgitant volume. So thinking about the structures that you need to image, thinking about how to optimize your imaging windows is always important when you're dealing with three-dimensional imaging. The aortic valve, there's been a lot of talk about the aortic valve and using three-dimensional imaging for annular dimensions. This is just me using the regular three-dimensional 3DQ that's on this particular echo machine in order to use the orthogonal long-axis views to get down to the annular level, and you can see how easy it would be to planimeter the annulus using that package. In addition, we've used the package to acquire the left coronary and measure the height of the left coronary to the annulus, as well as the length of the left coronary cusp. So three-dimensional imaging, again, extraordinarily useful. For the pulmonic valve, some of the extra imaging that we like to use is when we are in that long-axis upper esophageal view of the ascending aorta. If you just counterclockwise rotate, you get yourself into this beautiful, and this is us, just counterclockwise rotating from the long-axis view to yield this beautiful long-axis of the pulmonic valve, which, again, you can image in a biplane view as well. The pulmonic valve, one of our favorite views, is going to be your deep transgastric view. Again, from the inflow-outflow view, one can get both the inflow-outflow pulmonic as well as the basal RV pulmonic. You can color, you can Doppler. You're very on axis for any Doppler measurements. The tricuspid valve, as I've already shown you, can be seen in multiple different views, remembering that the 3D orientation by convention is to have the interatrial septum down or inferior, and then the anterior leaflet to the left of the screen and the posterior leaflet to the right. This is a patient with a prosthetic valve that because of rheumatic mitral valve disease, and you can see also has rheumatic tricuspid disease. So this is, again, septal leaflet, anterior and posterior leaflets of the tricuspid valve. Pulmonic veins, we've gone over, so I'm going to just skip this slide, but obviously multiple different ways to look at the pulmonic valve. The left atrium obviously has become a structure of great interest recently. We like to Doppler the left atrial appendage at the os or orifice in order to determine the risk for thrombus formation. It's really the forward flow out the appendage that we're interested in. So the flow above the baseline from these views, and with anything less than 50 having increased risk for thrombus formation, but obviously 20 being a high risk, very high risk for thrombus formation. When one looks at left ventricular size and function, obviously all the mid-esophageal views of the mitral valve will also give you views of the left ventricle. We like to use the biplane imaging in order to be sure that we are on axis for the, in this case, 4-chamber and 2-chamber view. And from this view, we can sometimes, if we adequately image the apex of the ventricle, we can use a biplane Simpsons in order to get the volumes and ejection fraction. But frequently, the mid-esophageal views will foreshorten the apex, and so one has to be quite cognizant of that. In general, the absolute volumes that one gets using TEE will tend to underestimate the true volumes of the left ventricle. But of course, when you're calculating an ejection fraction, you normalize for that type of error, and the ejection fractions tend to be relatively robust. In the transgastric views, we will not infrequently use the biplane or simultaneous multiplane imaging in order to see how on axis we are in order to do our measurements. These diverge a little bit from the original guidelines and from the chamber quantification guidelines in that we recommend not attempting to measure, in this case, this is the septum and posterior wall, but these walls are now in the lateral plane, and the lateral gain resolution is so limited that I think there's a significant error when attempting to measure that dimension. So rather than using that dimension, we would qualitatively use the dimension shown, which would allow us to use structures that are more perpendicular to the insonation beam and allow us to have more consistency in our measurements from TEE. Saline contrast studies, obviously an important aspect of TEE, particularly in those patients that come for cardiac source of embolus. The appearance of greater than 3 bubbles in the left heart soon after the opacification of the right heart, typically within 3 beats, is most consistent with a patent foraminal valley, but one must remember that the timing of the bubble appearance in the left heart is not a reliable indicator of shunt location, since it is significantly influenced by the size and intensity of shunt flow. In addition, the failure of the interatrial septum to move toward the left atrium, even when the right atrium is well opacified, should be considered an indeterminate bubble study. So if you do not increase right atrial pressures greater than left atrial pressures, and therefore cause the interatrial septum to bow into the left, then you cannot absolutely be certain that there is no shunt at the level of the interatrial septum. Coronary sinus can be very important, particularly in the operating room. There are numerous ways of imaging the coronary sinus. These are just a few of our favorites. So this is from, if you take a 2-chamber view and you counterclockwise rotate, that counterclockwise rotation from, again, a 2-chamber view will bring you into the plane of the coronary sinus. And so this is just the posterior wall of the LV and the coronary sinus in view A. In view B, we are in a bicaval view. From the bicaval view, if you retroflex, so the bicaval view would be not in this plane, but if you retroflex slightly, you should be able to get the coronary sinus coming in around the back of the left atrium. This is obviously IVC down here in liver, but the coronary sinus rides up around the back of the left atrium. And then finally, if you further insert the probe, you should also be able to, since the coronary sinus rides just on the diaphragm, you should be able to see the orifice of the coronary sinus quite well. And so those are some of the best views for coronary sinus imaging. Remember also that we can get a good look at the inferior vena cava. This happens to be a catheter coming up from the femoral vein, so it helps us identify the IVC. And so you can see the IVC as well as hepatic vein. The hepatic vein in these views tend to be extraordinarily on axis for Doppler if you want to, for instance, evaluate a patient for constriction. You can go ahead and put a pulse wave Doppler here and watch during the respiratory cycle. TEE can be performed for known or suspected adult congenital heart disease, a comprehensive TEE should be the initial test for evaluation of patients suspected of having adult congenital heart disease. The diagnostic utility of TEE is most apparent in circumstances where transthoracic echo is non-diagnostic or equivocal, as has been discussed previously. And while TEE is more feasible in the operating room, cath lab, or emergency department, it can be complementary to transthoracic in the regular echo lab as well, and particularly for looking at intracardiac shunts and extracardiac baffles. We propose or present an imaging guideline for some common adult congenital abnormalities. This is by no means comprehensive, but gives you an idea at least of the type of imaging that you can perform when you are evaluating patients with the most common adult congenital heart disease issues. And so I hope that you've now gotten an idea of the general indications, contraindications, and appropriate use for the TEE, the comprehensive examination, that you're able to describe the general assessment and preparation, as well as recognize and acquire the new 28 views of the comprehensive exam and explain how to use those 28 views as well as others in the evaluation of structural heart disease. And I'll just close and mention that the TEE guidelines are now in poster form, and these can be acquired at ASE at asecho.org. And I thank you for your attention. So I will break now for some questions if there are any. And let me just go to the pending questions here. Right now, I only see question 8 and 9. Okay. Really, I invite anyone who's listening. Hopefully, there's someone listening to write in your questions. But the main differences. One of the questions was, what is the main difference between this guideline and the 1999 guidelines? And I think that the main difference is that we included 8 extra views, which I think would emphasize that we can evaluate all of the structures in the heart well, including pulmonary veins, left atrial appendage, and the right ventricle. Those are all structures that I think were underplayed in the original perioperative guideline and are now more emphasized in this guideline. In addition, this guideline attempts to show the nuances in acquiring images for specific structural information. You cannot rely just on the 28 views, but really use multiple views, even ill-defined views for specific patients when you're going after some structural abnormality. And so the structural imaging section was an attempt again to do that. Another question is, could you discuss the use of commercial contrast during TEE? That is addressed a little bit in the guidelines. In the left ventricular section, there's an entire discussion of intravenous contrast. But we've used intravenous contrast in TEE for a number of different things. I mean, you can be quite creative. Remember, it's going to get across to the left ventricle. So sometimes we've used it to better define, a structure in the aorta or a thrombus that could be anywhere. We've used contrast intraprocedurally to diagnose a rupture. So we see small pericardial effusion. We're not sure actually if there's any extravasation. We go ahead from an aortic rupture, let's say, or just a micropuncture. We inject the intravenous contrast, and we see it extravasate into the pericardial effusion. So, I mean, similar to the use of contrast for endocardial definition, for border delineation and border opacification, you can use it for that, but you can also use it for a variety of different things to make the diagnosis of different abnormalities. Let me keep going. What would be the best view to view 3D images of the pulmonary veins. You know, I actually had a 3D pulmonary vein image in there, but I thought it was too esoteric, but I guess not. But the 3D pulmonary veins will usually go to whichever view, either at 0 or 90 degrees, gives us the cleanest view of the borders, remembering that you have near-field gain problems. So you either have ring-down artifacts sometimes, or just it's very, very near field, and so sometimes you'll have difficulty with the pulmonary veins. The time that it's been most useful to look at the pulmonary veins is, for instance, when you have a sinus venosus ASE and you want to rule out anomalous pulmonary venous connection. Boy, the 3D is absolutely beautiful. So any view that gives you a clean border, because the pulmonary veins are so near field that they're hard to see. When looking for small mitral prosthetic paravalvular leaks on 3D TEE, not visible on color, I have difficulty orienting the anatomy. That is so true for everyone. How do you perform evaluation of location of paravalvular leaks? Okay, so this could be really, really tough because obviously you need a really large field. You can no longer live with a 30 by 60. If you live with a 30 by 60, then I recommend a couple things. When you're doing the live 3D imaging with the 30 by 60 view, the 60 is in the lateral plane, and the 30 is in the elevational plane. And the machine will default to giving you, or you can tell it to give you the front 30, the middle 30, or the back 30. And if you know where you are oriented in your primary view, then you can just acquire 3 separate views and try and mentally reconstruct. But the thing that I think is the most useful is to go ahead and use the full volume color. Full volume color is a very, very wide sector and gives you, unfortunately, pitiful frame rates or volume rates. So typically a full volume color will give you a frame rate of 4. Now, you can't tell systole from diastole with 4. And so once you go to full volume 3D color, you're going to have to splice it. And so those patients that are able to hold their breath, you can splice an image together. Those patients who are in atrial fibrillation, you're kind of out of luck. You're going to have to mentally reconstruct a little bit more, just as you've implied. It can be a little bit difficult. But as long as you include in your imaging plane some other structure so you can orient yourself. For instance, if you have the aorta in view, you know where anterior and posterior is. If you have the left atrial appendage in view, you know where lateral and medial is. If you see a coronary sinus, you know where posterior is. So those types of things may help you. How easy or difficult is it to count the number of bubbles crossing in 3D? Oh, yeah, so I use the biplane because it's really the maximum number of bubbles in any imaging plane. And so biplane allows you to actually see 2 different planes. And how difficult is it? If they're all bunched together, they're going to be hard to count. Now, do you need to count? That's a toughie because I think that there are some people who will grade the severity of the shunt by the number of bubbles using as partition coefficients, as partition numbers 10 and 30. So less than 10 is small, 10 to 30 is moderate, greater than 30 is severe. But others don't believe in that because I think a lot of how much crosses is really how deep your Valsalva release was and how high the right atrial pressures are in relation to the left atrial pressures. And so I think there are others that don't believe counting is going to help you that much. You're going to rely more on the clinical scenario to help you decide whether or not you should close that hole. Are there any specific guidelines to obtain views as a part for evaluation of the TAVR workup? There are no specific guidelines out now, but in the same issue as the TEE guidelines is an article that I published. We can go to the, if you wouldn't mind going to the, I can go to the backup slides myself. This is one of the other papers. It shows you our method for at least acquiring the annulus. Now, you can use that or not, but there are numerous recommendations. There are no strict guidelines for TAVI, but there are at least 3 recommendations. One of them is the first author is Blumfeld, and Jose Zamorano, Pepe Zamorano, author was the first author on another multimodality imaging guideline for TAVI. All of those you can look up. There's been nothing recent. Those are all from at least 2012, 2011. Another question, how do you use contrast to evaluate left atrial appendage when there's a question of thrombus? Yeah, so, I mean, I don't actually tend to use contrast. There are people who do use contrast. I tend to just sit on the left atrial appendage and watch it and either record it. You can record by time or by beats, and I tend to set it to time and watch it for literally 30 seconds. You don't have to record it if you don't want to. You can just sit there and watch it. But the bottom line is smoke will eventually move, whereas a thrombus will not. In addition, thrombus will tend to have borders. They should definitely be seen in multiple planes. Planes should make sense and be representative of a mass. And so I don't tend to use contrast, but others have. Now, are there specific settings? The unfortunate thing is even smoke can sometimes prevent contrast from getting to the apex. So I'm loath to give you any recommendations because, we know from even CT studies that you can frequently not fill the apex of a left atrial appendage just from smoke. So I wish I knew, but I don't have any recommendations for you there. What are your thoughts on doctors who are opting to anticoagulate patients and cardiovert 6 weeks later as opposed to TEE and cardiovert immediately for AFib patients? Well, this would be my opinion, obviously, which I'm loath to render since, again, it's just a single person's opinion. I think either has shown to be relatively safe. I think some of it depends on how long you want to leave that patient in AFib and what the risk of anticoagulating for a long period of time. So remember, you're not only going to anticoagulate for the 6 weeks prior to the cardioversion, but for a good 6 weeks after the cardioversion. So if those patients are at high risk for anticoagulation, well, I would frankly, opt to do the TEE and shorten the anticoagulation duration. But I think that I can't, say that one is necessarily better than the other. I think both have been shown to be relatively safe. The only other consideration is that the longer a patient is in atrial fibrillation, the harder it tends to be to get them out, and the longer the period of mechanical standstill, even after you recover electrical activity. Boy, I think we're going to run over, but do you run through imaging of pulmonary veins? So pulmonary veins, I think we covered a lot of they were in that slide. I'm going to back up the imaging to the pulmonary veins, which I glossed over a tiny bit. So I think they came just before this. But I like imaging them at both 0 and 90 degrees, but my favorite is the 90-degree view. So both of these, this is the right and the left. This left one happens to be with a biplane, but both of them are obtained between 90 and 100 degrees. And the right veins are just, if you go from a bicable and clockwise rotate, that right vein just shows up. It's just phenomenal. And on the left side, if you're near the appendage, if you've got a good view of the appendage, just counterclockwise from there, and you'll get the pulmonary vein. So those are the easiest ways to get the pulmonary vein. Do you try to look at the ostium of the neck vessels in all your studies? I try. Obviously, some of it depends on how well the patient tolerates it. The neck vessels tend to be the last thing we look at because we're pulling out of the aorta. So we've now gone in, and in our protocol, it would be the last thing we image. So consequently, the patient is now less sedated, and the topical anesthesia is wearing off. And a lot of times they just don't give you enough time to image. But in addition, once you have the probe near the hypopharynx, they start to gag a lot. And so sometimes it's just not possible. Do I try? Yes, I do. And as I'm pulling out, not infrequently, I'll decide to pick one carotid or the other, and I'll pull out on the carotid. So as you're pulling out the neck, obviously you're going to have to decide left or right because you're only going to be able to image one. Let's see. What is the incidence of CVA within 4 weeks of TEE cardioversion? The incidence is not, I can't give you a number because I don't know the number offhand, but it is not trivial because there is mechanical standstill after cardioversion for atrial fibrillation, particularly of unknown duration. So, the shorter the duration, typically the faster the recovery of mechanical function. So even after cardioversion with electrical conversion, you've got mechanical issues, and you want to anticoagulate afterwards. Sometimes you can't, and that's why you're cardioverting. The patient cannot be anticoagulated. but the risk then of CVA in the weeks after cardioversion are not trivial. Is it possible to comment on left atrial appendage descriptions on 2DE, cauliflower, chicken wing, etc.? Yes, it is. So, we obviously use biplane imaging. I'm going to go back to the slides one more time and see on left atrial. So this is a cauliflower. And we can see cauliflower, chicken wing, and windsock. Those are the main types. There's also one called a cactus, which is typically multiple well-defined lobes. So the cauliflower or broccoli or whatever you want to call it, I call this a fan. These are all the same structure, tend to have this very wide, very trabeculated, wide section of the left atrial appendage, and you definitely can tell anatomy based on 2D echo. I wish I had examples for you. I mean, I have them elsewhere. I just don't have them on this presentation. But the highest risk for clot, it turns out, as far as morphology is concerned, is this one. So the cauliflower / broccoli / fan, whatever you want to call it, this is the highest risk for clot formation in the patients with atrial fibrillation. Okay, and 2 studies looking at that actually confirmed each other. From the mid-esophageal, okay, I guess people are leaving so, I mean, there are a ton of other questions. I'm really, really sorry I'm not going to get to all of them, but I guess we should probably wrap up. I think Rana needs to speak to everyone.
Yes, everyone. Thank you very much, Dr. Hahn, for presenting today, and also thank you to all the participants. I wanted you guys to all keep in mind that we encourage you to download a copy of the guidelines and the PDF slides. I know some of you had some trouble, so you can definitely use these to view within the next few days, as well as any trouble you've had with the player. We will be having a recording available, and it will be on your ASE University profile under live events. And you'll be able to view the profile and view the webinar there. And also I wanted to let you know that we have another live webinar coming up that will be a review of the pericardial guideline by Dr. Alan Klein. This will be held on Monday, November 4th at 5:30. Without any further ado, I know some of you are needing to leave, but if you stay on the line, you'll be redirected to claim your CME for this live webinar.